Scott Jensen here. For whatever reason, this has been the week where my patients, and actually even some acquaintances that are not necessarily patients of mine, have had questions about life and death and menopause and andropause. And I thought, that's a topic we haven't talked about. So I'm going to just jump in. There was an article written several months ago in the Wall Street Journal. Josh Zumbrin wrote an article February 11th and 12th of 2023, and the title was Plan on Living Past Your Life Expectancy. If you go back 120 years, 1903, Wilbur and Orville Wright were able to launch the first airplane. What was the average lifespan approximately in 1903? About 50 years of age in the United States. What does that mean? Well, if you're going to die at 50, then if menopause is this relatively abrupt reduction in female hormones from the ovaries in a woman, and it starts at 50, that would mean that many women would never have many symptoms of menopause. And if andropause is that more long drawn out process of hormone reduction in men that occurs in the 50s, men also would not necessarily experience many symptoms of andropause. Additionally, separate from andropause for men is the reduction in sexual function in regards to erections. So erectile dysfunction would be something that men in the early 1900s might not have been as acquainted with because they were already dead. So this article talking about your life expectancy 120 years after Wilbur and Orville Wright got their airplane up in the air is interesting. Right now, I think roughly a lot of doctors would tell their patients that the average lifespan for an American is about 80 years of age, if you make that determination in terms of kids being born today. If you get more particular, I think you could find a fair amount of data that would say a typical woman born today would have a life expectancy of 81, and males would be around 75 to 77. But this article was interesting. It says this: according to the latest data from the Social Security Administration, the oldest members of Generation X, or the Gen Xers, these would be people who led the way for Gen X. So that means they were the first ones to follow the baby boomers. And the baby boomers were 1946 to 1964 birth dates. So Gen Xers started in 1965. So if you take that Gen Xer, they are right now going to be somewhere around 58 years of age. In 2032, 9 years from now, they would reach the full Social Security retirement age. And from that point forward, so in 2032, the oldest leaders of the Gen X, they would be 67, full retirement age. From that point forward, non-smoking males would have a 47% chance of living to age 90. That's a lot longer than what was happening with Wilbur and Orville Wright. So if you're a non-smoker and you're male, you'd have a 47% chance of living to be 90. And if you're a female and non-smoking, you'd have a 57% chance of living to 90. That means men are almost 50% likely to live to be 90, and women would be almost 60%. And then there's a graph in this article, and it says, what is the probability of someone alive today reaching 100 years of age? Well, if you look at women in good health today, if a woman is 70 years old and in good health, she has a 16% chance of living to be 100, 1 out of 6. If you're a man and you're in good health, excellent health, and you're 70 years old today, you have a 10% chance of living to be 100. Now, I never thought that I would have a ghost of a chance of living to be 100 because my family tree doesn't have long lifespans. And so I just figured that I didn't think I'd even make the average. But I'm in pretty excellent health, thankfully, and I'm 70 next year. So arguably, that could say that I have a 10% chance of living to be 100. That's fascinating, I thought. So I think what we're saying is that our life expectancy is probably greater than we might have thought the averages would call for. But we also can then start to talk about when are we going to die? And that has impact in regards to your savings, and are you comfortable, and have you taken care of business, and have you done living wills and things like that. And that's important to do. Before I jump into menopause and andropause, I want to say this. I'm just talking as a generic physician who sees patients and talks about menopause and andropause all the time, but I'm not giving you any medical advice. You need to talk to your doctor about that. This is not meant to be speaking for anybody else other than just Scott Jensen's perspective. So please, this is not medical advice. I don't know anything about you. I don't have your chart in front of me. I'm not giving you medical advice. American Family Physician, one of my favorite journals. Today's edition comes out, and you'll see it has a Scrabble board on it. Now, yours might be reversed because I'm doing this Facebook as a mirror image, but right across the middle of it, it says menopause. A terrific article in the edition was July 2023, American Family Physician. The article was Managing Menopausal Symptoms, Common Questions and Answers, written by Jennifer Chang, Dr. Megan Lewis, and Dr. Maggie Wirtz. I thought it was quite good. There's always this discussion going on about, well, can I take hormones or not, or what can I do to mitigate the symptoms that are coming on with the menopause? This article speaks with some clarity, and I think it's important to recognize that the science is not established. I think science oftentimes is a tool whereby we slowly over time approximate truth, but oftentimes the truth is elusive. So anyway, this is what this article says. There's two kinds of symptoms that we really talk about with menopause. We talk about vasomotor symptoms, and we talk about genitourinary symptoms. This article says this: vasomotor symptoms, hot flashes and night sweats. So tuck that into your brain. Vasomotor symptoms are hot flashes and night sweats. Very problematic for a lot of women. And then the other category of symptoms is genitourinary symptoms, vulvovaginal irritation and dryness, dyspareunia or pain on intercourse, urinary problems, and also can affect mood, sleep, sexual function, bone health, and overall quality of life. It goes on to say this: vasomotor symptoms, hot flashes and night sweats, may affect as many as 80% of women worldwide and last on average, wait for it, a total of 7 to 8 years, including 4 to 5 years after the final menstrual period. A lot of times I have told women that most of their symptoms will start abating after 24 months from their last menstrual cycle. But again, check with your doctor. Bottom line is, these are a big deal. One of the big questions that comes up all the time is, what about hormone therapy? There's a lot of different things we can do to, again, reduce the impact of many of these vasomotor or genitourinary symptoms. But I really appreciated the clarity with which these authors spoke. And this is what they said: menopausal hormone therapy containing estrogen is effective for treating vasomotor symptoms of menopause. Vasomotor symptoms? Hot flashes and night sweats. Goes on to say, unopposed estrogen is known to increase the risk of endometrial cancer and should not be administered without progesterone in women with a uterus. Let's unpack that just briefly. Unopposed estrogen means we're giving a patient just estrogen without anything else. And if we do that in someone who has a uterus, we increase their risk of endometrial cancer. And we should not do that without adding progesterone to that estrogen so that we get some cycling of that uterine lining. Cycling that uterine lining, whether it be monthly or quarterly, can reduce the potential increase in risk of uterine cancer. You need to talk to your doctor about that. But again, if you've got a uterus in place and you take estrogens alone, you can cause a hyperproliferation of the lining of the uterus, which is thought to potentially increasing the risk of uterine cancer. But here I thought was really a good statement. Estrogen-only hormone therapy may reduce breast cancer risk in those with a hysterectomy. So if you don't have a uterus, then you don't need to add progesterone or progesterone supplements to the estrogen. You can treat with estrogen alone because you don't have a uterus that can experience an increased risk in cancer. And estrogen-only hormone therapy may reduce breast cancer risk in those with a hysterectomy. That has been something that's been bantered about for decades. But then they go on to say, whereas estrogen, progesterone, hormone therapy may increase the risk in those with a uterus. So if you've got a uterus, you need estrogen and progesterone to deal with the hot flashes and night sweats. But in doing so, it appears there may be an increase in breast cancer risk. But with women without a uterus, estrogen therapy alone seems to reduce breast cancer. So that's sort of the state of the discussion today. A lot of the information that we get in regards to estrogen and progesterone therapy comes from the Women's Health Initiative, a large systematic review and a study. And this is what this article says. Long-term 18 years of follow-up of the Women's Health Initiative concluded that there was no significant increase in the risk of death from all causes or cardiovascular causes among women receiving hormone therapy with conjugated estrogen alone or conjugated estrogen and progesterone during the 5 to 7 years of treatment. So that's pretty good news. All-cause mortality is not increased. I wanted to comment one other thing about this article. They also mentioned some non-prescription drug issues, and I thought that might be helpful as well. They made the comment that non-pharmacologic treatments that might be effective for the vasomotor symptoms, hot flashes, and night sweats include black cohosh and isoflavones are shown to be effective compared to placebo, but they're not significantly more effective than hormonal preparations, and they lack standardized formulations. And that's black cohosh and then isoflavones, and you might have heard of isoflavones or you might not, but they're phytokines, and they are like estradiol, they mimic it, and they're a precursor to the estrogen hormone. So they can raise your overall serum estrogen in your body, but they come from beans and peas and lentils, legumes, if you will. So that's where the isoflavones. So the isoflavones and the black cohosh can be an approach to treating the menopausal vasomotor symptoms, as well as pharmacologic agents. Now, we should talk about andropause as well, because that's sort of regarded, according to this article by Ilyana Bisha-Tagani, an MD who wrote for Gilmore Health on April 12, 2019. She referenced andropause as, it's the male version of menopause. Okay, so what does that mean? That means males go through this elongated process. I usually tell my male patients, it typically starts 50, early 50s, and probably lasts to 60, early 60s, 10 years. And during that time, there will be a slow degradation of testosterone, or I shouldn't say degradation, a slow reduction in the amount you make of testosterone, probably 1% per year. You probably start that reduction somewhere in your late 30s and 40s, where every year your testosterone production from your testicles drops about 1%. What does andropause present with? I'm just going to read a bunch of entities that we have to deal with, and I apologize if I'm causing men to be depressed. But here's what it is. Declining cognitive function and depression, gynecomastia or enlargement of the breasts, loss of elasticity and thinning of the skin, testicular atrophy where your testicles get smaller, decreased sexual desire or your libido drops, reduced levels of testosterone, thinning hair loss, reduced muscle mass or strength, increased fat mass, and abdominal obesity. It seems like a lot of times our weight sinks from our chest muscles down into our belly. We go from looking like an hourglass maybe to more of the Pillsbury Doughboy. And then a reduction in bone mass and osteoporosis risk. That's what andropause can do. So it's a significant change in a man's life. And there's no question about it. The question comes up all the time is, can I reverse it or stop it with testosterone supplementation? Well, again, I mentioned before, testosterone levels in men decline about 1% per year, starting in the 30s or 40s, and it continues onwards. it causes change in sexual function. But I think one of the common misconceptions that I deal with in the office is if men would replace their testosterone, would they then restore their erectile function to a more normal pattern that they're accustomed to? And generally not. Yes, testosterone supplementation can reverse a fair amount of those symptoms I just went through, and certainly increase your libido, your desire for sexual activity. But in terms of actually enhancing and restoring your erections to what you were accustomed in your 20s and 30s, probably not going to happen. The Mayo Clinic, I thought, well, people might want to know what does Mayo Clinic say? So I went to Mayo Clinic's website, and it says testosterone therapy, potential benefits and risks as you age. And Mayo Clinic, this article says it's entitled Sexual Health, Testosterone Therapy, Potential Benefits and Risks as You Age. And the author was Mayo Clinic staff. And here's what it says. As you age, testosterone therapy might sound promising, but there are a lot of misconceptions about what the treatment can and can't do for you. And then it talks about what does testosterone do? And this is what Mayo Clinic article says. Testosterone helps maintain men's bone density, fat distribution, muscle strength and mass, facial and body hair, red blood cell production, sex drive, and sperm production. Then it goes on to say, as you age, your testosterone level gradually declines about 1% a year after age 30 or 40. Then it goes on to say, later on, what are the risks of testosterone therapy? And these were the risks, and I think they're important to know. Worsening sleep apnea, causing acne or other skin reactions, enlarging breasts, limiting sperm production, stimulating too much red blood cell production, which can contribute to the increased risk of forming a blood clot. And certainly not last, or not least, I should say, stimulating non-cancerous growth of the prostate and growth of existing prostate cancer. I oftentimes tell my patients, adding testosterone to your body mix may not cause prostate cancer, but if there is underlying prostate cancer, whether it's been detected and diagnosed or not, it would be potentially like testosterone would be adding gasoline to a fire. So if you have a prairie fire that you're trying to put out and you add gasoline, you're going to flare that prairie fire. Same thing with if you have a prostate cancer that has foci of cancer in the prostate that hasn't been detected, and you put testosterone supplementally into the mix, you may well flare that prostate cancer and cause problems. There are studies that indicate that testosterone supplementation will increase your PSA, and your PSA is the prostatic specific antigen, or the blood test that we use to measure risk of prostate cancer in men. So I think those things are important as well. So we've talked about menopause, we've talked about andropause. I don't think there's any question. Both men and women go through that middle of their lives aging process that causes significant problems. But I also want to talk about diabetes, because we're seeing a virtual epidemic of diabetes, and increasingly we have to ask ourselves the question, will we die with diabetes? And as we approach death, will diabetes be the cause of our death, or will it be a contributing factor in our death? Washington Post wrote an article earlier this month, and it said, diabetes to double worldwide by 2050, mostly because of obesity. And I think it's an important article for several reasons. First off, it says this: the number of people worldwide with diabetes is projected to more than double in the next 3 decades, reaching 1.3 billion by 2050, according to research published in The Lancet. Lancet is a United Kingdom or English journal, highly regarded. Let's unpack that just a bit. 2050 is less than 27 years away from us. 1.3 billion, what does that mean? Well, there's approximately 8 billion people in the world. You probably know that China and India are both about 1.5 billion. The United States is 325 million. And those are 3 of the leading countries in terms of population, but certainly India and China have a humongous number of people. But we're saying that out of 8 billion people in the world, 1.3 billion would be having diabetes by the time we get to 2050. What does that mean? Well, right now, the prevalence of diabetes, or the percentage of people right now in the world that probably have diabetes, is probably around 6%, maybe a little less, maybe a little more. And it's thought that it'll rise to about 10% in 2050, perhaps even a little higher. And the researchers found that right now we have 529 million people with diabetes in 2021. So 500 million, okay? That's about 1.5 times all the people in the United States. But that's going to go from 6% to 10%, which would be, again, 1.3 billion people potentially by 2050. 2050, obviously, we'll have more than 8 billion people, will be higher. But I think one of the most compelling things about this article in the Washington Post is this. The researchers found that about 96% of people worldwide who had diabetes in 2021 had type 2. In days gone by, people would ask me, how many people that have diabetes have type 2 diabetes and how many have type 1 diabetes? I would always tell them about 5 to 10% of diabetics are type 1 and the rest are type 2. Now we actually have a hybrid kind of diabetes we call LADA, L-A-D-A. But the bottom line is somewhere around 90 to 95% of people with diabetes have type 2 diabetes. The researchers confirm this by saying 96%. But this is what they say. The increasing prevalence of type 2 diabetes worldwide is primarily due to a rise in obesity. They wrote that the continued global spread of diabetes presents a massive public health challenge for policymakers, healthcare professionals, and patients. I thought, people want to know probably, if I get type 2 diabetes, what does that do to my lifespan? And since this conversation is discussing lifespan, I found this article in Diabetes Home and it said this. At age 50, life expectancy, the number of years a person is expected to live at the age of 50, is 6 years shorter for people with type 2 diabetes than for people without it. So if you're 50 and you're diagnosed with type 2 diabetes, boom, your lifespan just dropped 6 years. This article went on to say that there are 4 treatment metrics or measures that we might look at regarding diabetes. The first one, body mass index. It's a measure of your weight and height. Lately, it's been ballyhooed that maybe we shouldn't be using the BMI so much, but quite frankly, we don't have anything better, and we've got a fair amount of history with BMI, so I don't think we should throw the baby out with the bathwater. So let's just, BMI matters. A1C is an average of your blood sugar over the last 3 months. That's another measurement. Third one is your LDL cholesterol, and that contributes to plaque buildup. And then the fourth one is your systolic blood pressure, or the first number in your blood pressure, 120 over 80. 120 is your systolic blood pressure. That's the blood pressure number that relates to the contractile force when the heart is pumping, while the lower number, the diastolic blood pressure, has more to do with what the pressure is during the relaxation phase of the heart muscle. But those are the 4 things we look at. We look at the BMI, the A1C, the LDL, and the systolic blood pressure. And what they said in this article is reducing your BMI on average was associated with the greatest gain in life expectancy, followed by second place was A1C, reducing your A1C. So in summary, there's no question. We're living 30 years plus beyond what Orville and Wilbur Wright were living in their day. We have a tremendous potential to live to be into our 90s and even to 100 if we're in good health now and we're somewhere around 50 to 70 years of age. We know that menopause and andropause are significant disruptions to the rhythm of the life we're accustomed to, but you can't ignore them. And we also need to understand that trying to reverse or retard the effects of those 2 processes, menopause and andropause, have risks. Men need to understand that adding testosterone to their body exogenously, whether it's pills or injections or topically on skin, has a risk, and you need to talk to your doctor about it. We also need to understand that obesity is driving us and driving this epidemic of diabetes to a place where we likely will have some regrets that we didn't address it sooner. It's going to push hundreds of millions of people to the diagnosis of diabetes, and that will shorten their lifespan. So, what's your life expectancy? When will you die? How will you deal with andropause or menopause? And will you die with diabetes? Big questions. If you're not willing to discuss them, I guess you'll take what you get. I think it matters, and I think we can enhance the quality of our lives if we have these kind of conversations. I think you should have them not just with your doctor, PA, nurse practitioner, therapist, or whoever. I think you should have them with your family, because perhaps together you can rally and you can reinforce one another's efforts to really be the best version of who you can be tomorrow in regards to your overall health. After all, it stands to reason, if someone's going to really champion and promote your health, I think it has to be you. Have a good day.